Today, we're bringing you a special edition of the SiteCast. I'm MD Edge editor Terry Rudd. As the nation's healthcare system wrestles with a rising number of COVID-19 cases, physicians who've faced the pandemic first have some critical lessons for everyone. I talked recently with two Seattle area critical care leaders about some creative approaches to ready that region's critical care departments. One of those creative approaches uses a smartphone's simplest feature, texting. Dr. Ann Lipke is the medical director of Swedish Medical Center's Issaquah campus in suburban Seattle. Dr. Lipke explains how texting has become a fast, effective component of Seattle's critical care response to COVID-19. And she offers lessons for her colleagues across the country faced with situations similar to Seattle's.
My name is Ann Lipke, and I am a physician at Swedish Medical Center. I'm the medical director of the Issaquah campus. Swedish functions over 4 campuses and has 6 ICUs in those 4 campuses. Many of them are, 2 of them are subspecialized to be a cardiovascular ICU, one's a neurocritical care unit, one is surgical, and then the rest are general medical. So our bed capacity is pretty large. It's flexible, of course, during this time. So we've been expanding our bed capacity, but I believe it's close to maybe more than 70 beds. I think it probably is. I'm sorry, I don't have an exact number for you. We are a referral center, so a large private group in town that's a referral center for specialty care, and serve to a number of partners in the community around the area that are associated with the Providence Network and other hospitals in the region. When this started, we were all struggling because of a lack of information. So we had heard through the grapevine that Evergreen had those initial cases at the end of February, and by Monday we had a case also at the Issaquah campus already. By that Monday, we were all struggling to know what was happening in the rest of the city, and I actually don't anticipate this happening on the East Coast because they've gotten sort of fair warning that this is starting. But for us, it happened all really quickly. And because of that, although all counties and regions have disaster plans, actually enacting them and making them get up and running is a little, particularly at this large of a scope, is a challenge. So I decided on Monday morning to reach out to all of the ICU directors of all the hospitals that I knew in the area. And thankfully, critical care is a relatively small community, and we tend to know each other. And within cities, we all know each other. So I started a text chain on Monday morning. So we connected all of the hospitals in all of the ICUs in the region in real time. And it's been a godsend for us because it allows us every day to check in with each other and review things like what our census is, how many patients that we have that are COVID positive, how they're doing, who's being extubated, and of course, all in sort of anonymous way, but for us to get an idea of numbers of, what the sense of the illness is, what the duration, which is longer than typical ARDS. It's allowed us to get quick clinical information from colleagues. For example, Melissa Lee at Evergreen, who's been heading up their efforts, she's the director of their ICU, was able to share with us very quickly their observations about the cardiomyopathy that happens with their patients and give us some clues so that we didn't have to reinvent this, so we could have in real time things that we should be observing, things that we should be watching for, how to anticipate them, and learn from their experience very quickly. It's also allowed us to review what's happening with personal protective equipment in all of the units and make sure that our protocols are similar, because there is a lot of changing direction from the government about that. And it's allowed us actually to talk about patient distribution in real time. Usually that's run through networks of transfer centers. And while most of the time that works, in extraordinary circumstances, there are times that we just have to send a text out and say, we're full, we need we need help, and to get immediately contact from colleagues who, critical care by nature, critical care doctors are all very team oriented by nature. So we have joined really quickly as a team in the region.
How has the distribution list grown as the crisis has developed?
Yeah, it's funny. So I started it knowing with the people that I knew in town. So I reached out to the director at Overlake, the director at Evergreen, the director at VM, and University and Tonelli at UW, so he could connect us to Harborview and the University of Washington. And as it grew into Valley, so those are the big hospitals in town. But as it grew, it excluded some of the people who are a little bit farther north and a little bit farther south. Interestingly, later that week, I was on service, or the next week, I was on service in the medical ICU downtown, and got a page from somebody at Providence Everett, which is, farther north, who said, I don't actually need any help. I just wanted to call and talk, touch base with somebody. And I said, oh, were you not included in the text chain? I'm really sorry. And he said, what? And, so we added him on, and we have added on people sort of organically, to add on people a little bit farther south, a little bit farther east, to make this, it's actually a very robust network now. So I think it does include every hospital within a pretty large radius of us to make sure that we're all connected. And, as the region of the outbreak expands to include those hospitals, because we very much are concerned about avoiding crisis standards of care, and very clearly understand that does not happen in isolation. So we're functioning as a large network right now, and that our resources must be shared, including staffing and beds and equipment, et cetera. So we're trying very hard to make sure that no hospital gets to that standard of care. And this means of communication has been very rapid and very real time. And for that reason, it's been extremely helpful to us.
So has your phone been basically blowing up in your hand because now you're part of this pretty large network?
Right. I'm like a teenager now. I've never received so many texts in my life. So it's sort of a joke, but it's better because the emails, as you can imagine during this, the email chains that are going around are really hard to keep up with. And so this is one that we can prioritize, right? That it's an immediate point of contact. But yes, there are a lot of dingings, and people are respectful about it. I mean, there are morning check-ins, essentially, sort of a roll call of which patients are going on, what's going on with vent situations. And then there are small conversations about what's happening with shortages of medications that we're anticipating or that we're seeing. And so that it helps us all anticipate that, we might be running low on albuterol MDIs as a system, and what will we do if we get to that point, and discuss that as a group.
Are there plans to take this approach, this communications network that you've built now using text, and put it into another medium, into another format, something more formal? Yeah,
I think, there are two sides to that coin. Once a centralized control regional center is up and running, I think it would be a great way to communicate with each hospital rapidly. The issue, of course, is that it may not get to all people that need to know immediately. And it's more of a check-in, but it's a very fast and effective way to communicate with one another. As I mentioned, our hope is that eventually this will be centralized so that we have one regional control center that communicates to all of us and has a means by which to track every day where we are in equipment, where we are in medications, where we are in nursing staff and bed availability and ventilators and physician staffing, et cetera. And I imagine that will grow. But none of us has ever seen something like this in our lifetimes. So although we can be prepared for a disaster, I don't know that any one of us really had enough foresight to have this up and running with enough lead time to have effectively made that network. So it's conceivable that it will continue. I'm sure that some centralized control will like to sort of get access to it at some point, and we've actually kept it. We haven't offered it to anybody, but nobody's asked us for it either. So I don't know if it's well known, but I don't think any one of us has hidden the fact that we communicate in this way. And it's all, it's confidential. There's no identifying patient information that goes on It's just purely, numbers and resources review, and then information sharing about clinical management.
Is there anything else that you would want your colleagues outside of the Metro Seattle area, across the country, to know about your experiences and maybe some lessons that you would want to make sure they know now before they get to the point that you're at now?
Right. The things that I've been texting with friends on the East Coast from training, or people that I know in the critical care community. And the things that I've shared with them is, first, that this has been useful for us until a regional control center is up and running. So communicating with each other in the region is really important. I have been sharing about the cardiomyopathy that we've observed and some of the clinical aspects about it. I would strongly encourage people to get their telemedicine systems up and running. That was an anticipated need, but getting that operational to have outpatient management of, otherwise delicate patients that we handle in the outpatient world, with clinics being closed and restricted access, having telemedicine being robust and available and making sure that patients know how to access that would be wise at this point. And to know that, through all of this, my overarching sort of saving grace has been that it's really wonderful to watch our community rise to the occasion. And I'm sure that will happen in every community around the States, and probably, I'm sure, around the world as well.
So what else can the nation's critical care systems do to prepare for the pandemic's worst? Dr. Mark Tonelli is professor of medicine at the University of Washington Medical Center in Seattle. He's also UWMC's section head of the Division of Pulmonary, Critical Care, and Sleep Medicine. He talked with us about how the University of Washington and the Seattle region's other health systems have readied their critical care departments for COVID-19's demands. You no doubt have some detailed planning ready in terms of staff and supplies and beds and treatment. How are you conveying those plans to staff? And are you having to build new structures to kind of get the word out and communicate and coordinate all of this?
So yes, there's both excellent planning, but more importantly, implementation of contingency plans that are ongoing. The best plans you can have to be adapted to the current situation. So there's a lot of effort to adapt our standard contingency plans for this specific outbreak. Communicating that to the staff has been somewhat challenging in that there are a lot of different siloed populations, but at the University of Washington in particular, we've centralized all communications to staff and faculty, and then created a specific website, some of which is public facing for our colleagues in the community, and some which requires a university access that contains multiple documents that deal with everything from staffing, PPE conservation, updated clinical recommendations, a wide variety of available information at one site.
Do you have a plan B in case you have shortages in any of the areas that you're going to have to deal with? For example, retired staff, private industry, supply sources, tents, etc.
There's an entire alphabet of plans, I would say, for these things. Obviously, everybody's concern is that the most crucial resource that's likely to become limited relates to ICU level care. So there is a great deal of planning around surging our ICU capacity, which means surging our staff, surging the space in which we can provide ICU level care, and making sure that we have the equipment to do so. And those plans and implementations are ongoing. I think we need to recognize that we're going to have a significant amount of flexibility. We are reallocating and planning to reallocate space, stuff, and staff from other sites that are now or other services that are now less utilized. We've canceled all non-emergent surgery, so we have anesthesiology and surgical faculty who become available. CRNAs, our other ICU services have decreasing census, so moving advanced practice providers from one critical care area to another. Bringing people from outpatient, both nurses and physicians, into the mix. So the university overall has is collecting all the information it needs in terms of a staffing pool to help reallocate those personnel when needed.
Moving on to triage plans, is there a solid plan or plans for who's going to be hospitalized, who goes to the ICU, who goes back home?
So I think we need to make it clear that we are not yet in a condition of crisis standards of care. The system is quite stressed, and we are implementing a wide range of contingency plans, but we are not yet in a place where we as a region lack any crucial resource, including ICU capacity. We as a region do not want single hospitals to reach that level of crisis standards of care alone, as long as there are resources in the community. That's a particular challenge, and that it becomes very evident in a pandemic that we do not operate in a healthcare system, that there are multiple healthcare systems and individual hospitals within a region who are not particularly used to communicating with one another, with sharing patients and sharing resources. So building out that mechanism of close communication between institutions, the general understanding that we're all in this together, and trying to realize what resources are available so that one particular institution is not overwhelmed, has been a particular challenge.
You talked earlier about kind of reallocating staff. Do you have particular training approaches that you might be able to use to include staff that don't normally work in pulmonary or critical care?
Yes, we've been developing that, and obviously we're talking about respiratory therapists, nurses, and physicians who may not be used to working in a critical care environment. I would point out that the Society of Critical Care Medicine, I think just yesterday, announced that it would release or allow for its fundamentals, and you may need to check this before you post, because I'm not exactly sure what I think it's called the Fundamentals of Critical Care.
Sure.
Will be made available, which is an educational series, will be made available for free during this crisis, and that's going to be one aspect of our training clinicians and advanced practice providers and nurses to be at least familiar with critical care. The structure that's envisioned is that intensivists and critical care nurses will likely supervise care being provided by non-critical care clinicians as a way of extending our care to cover this surge capacity.
It looks like tried and true supported care is about all that's being recommended in the clinical guidelines. You can tell us just what that encompasses.
Good supportive care seems to be the key to this illness. I will say that most people who end up on mechanical ventilation are unlikely to survive. And so good supportive care prior to respiratory failure is crucial. And certainly once a patient develops respiratory failure, basic quality ICU care is going to be important to try to maximize the survival rate. There is no specific therapy for this. It appears that prone positioning may be helpful. We are involved and many of the sites in Seattle are involved in a randomized controlled trial for an antiviral medication. But otherwise, we just are trying to get patients through their viral pneumonitis and ARDS. I will also note that the length of stay on the ventilator both in terms of reports from China and our own early experience here, is quite long. So you can anticipate that a patient who ends up on the ventilator will likely be on the ventilator for a median of somewhere between 10 and 14 days, and that's for both people who survive and don't survive mechanical ventilation.
There are also reports out there about cardiology, liver, kidney complications in these patients. Is the preparation for those possible complications in some of the patients being incorporated into your planning?
So in particular, I think one of the concerns is that circulatory failure, either related to cardiomyopathy or not, seems to be fairly prevalent in particularly the older population of severely ill COVID patients. There is not specific management for that beyond standard circulatory support with vasopressors and inotropes. It appears early on that portends a particularly dismal prognosis. And then I'd say in terms of renal failure, that as well appears to be associated with a particularly dismal prognosis. There are multiple patients who are on renal replacement therapy in King County currently, none of whom have yet survived to liberation from mechanical ventilation.
Do you have a plan to communicate with the community about what's happening?
Yes, many of us have tried, or many of us are trying to speak to the community about the vital importance of social distancing and decreasing the spread of this infection, and also trying to give them a realistic sense of what impact this pandemic is having on the healthcare system. Because this doesn't just affect patients with COVID-19, this affects every patient who might need acute or urgent care. We'll need to attempt to maintain standards of care in all aspects of critical care medicine through this, but it's wrong to think that the challenges only face patients with respiratory failure due to COVID-19. The other thing I'd like to point out, not necessarily that was a question, I think the other thing that's crucial, that has been crucial for us early on, is actually close communication between critical care providers in multiple institutions and healthcare systems. Very early on in this process, one of the critical care providers in the Swedish system, Ann Lipke is her name, started a text thread with her colleagues in other institutions, and we now have the ICU directors and critical care directors in 14 different institutions linked together in order to provide each other information regarding census, strain on the system, as well as to provide real-time information about what we're seeing in these patients. It's been a tremendous, absolutely tremendous resource that's completely, that is not built into the system. It was something that has developed among a community of critical care physicians, many of whom know each other and are looking out for each other. And under the current situation where our healthcare systems may not be talking to each other well, and where it's a challenge to try to coordinate care between institutions, that's been a godsend. Right now, we're working with regional partners on the technology side to try to develop ways to get a regional reporting structure that can help with our regional resource allocation going forward. But we're having to build that from scratch. It doesn't exist.
Anything else that would be good to know that you would want colleagues elsewhere to keep in mind as this moves into their world? Absolutely.
So what I would say is don't wait until you have a problem. Like social distancing, implementing a healthcare surge needs to happen absolutely as early as possible. So even if you're not seeing a marked influx in cases yet, you should already be implementing plans for that surge. It's coming, I should say, and any delay in planning is only going to hurt you in the long run. The other thing I would just say is that in our region, every medical center has taken the brunt of this, and they took it in an unexpected fashion with no opportunity to really see it coming.
Mm-hmm.
They have done an absolutely tremendous job of implementing their contingency plans in very short order. I simply can't say enough about what they've done, and I think they really are a model for other institutions. It's been impressive to watch.
And that's it for our special episode on the coronavirus pandemic. We'll be back with new, regularly scheduled episodes later this week. Till then, thanks for listening and stay safe out there.